And I think you have another interesting
Yeah,
cases.
those were beautiful examples, Christoph. And I think what is also very intriguing, and specifically about actually virtually all of the cases that you presented, is that this shows you that IVUS should not just be used to guide PCI. It's also
Yeah,
the tool that plays a tremendously important asset in the workup of coronary artery disease. For instance, left main lesions. Yes, it could be that you find a somewhat ambiguous lesion in the left main, which looks about 50%. We've seen cases in which the MLA is 2 or 3. Whereas conversely, we've also seen plenty of cases in which the MLA potentially is 8 or 9, and those lesions do not warrant treatment. And the same counts for a lot of things that we encounter in routine practice. The angiogram is frequently misleading. I think that is something you stated multiple times, and that is absolutely true. That counts for calcium, very low sensitivity and specificity to detect really heavy calcium. That counts for osteal and left main disease, and that also counts for, in particular, cases like this of patients presenting with in-stent restenosis. And in this day and age, people have a very low threshold to use DCBs. But I think step number one is actually understanding what is the true pathophysiology of in-stent restenosis. Is that because there is a massive amount of neointimal hyperplasia? Is it all soft tissue? Is it calcium? Or is it because the initial stent was not properly implanted, meaning it was underexpanded? And obviously the treatment is different as compared to when the initial stent was properly expanded and now there's a lot of soft tissue obstructing the lumen. So this is just one simple example of a 74-year-old female who had a PCI of the LAD in the diagonal almost 30 years ago. So she comes back with stable angina, progressive now. We actually couldn't even cross with a balloon. We couldn't cross with an imaging catheter. So we actually used a rotablator to open this lesion. And then you use a 3mm non-compliant balloon to assess the patency of this old stent. I'm just going to show you a couple of cross sections that we found. So what you see here is you see the old stent actually nicely expanded. You see the stent struts shattering across 3mm distal to the catheter. But then you see in the middle very heavy calcium, and now obviously fractured by the rotablator and the trio balloon, but still the minimal lumen area is 2.1 in this mid-LAD of this still 74-year-old female in a proper condition. So obviously you could argue, well, we'll do a DCB, but if you already know that after a decent inflation with a trio non-compliant balloon, a angiographic result that looks actually quite good, but an IVUS is showing you a MLA of 2.1, there is in this case, for instance, not too much sense to do just a DCB, but potentially a new scaffold, in this case a drug-eluting stent, which would make more sense in order to get a proper increase in the lumen diameter, which is eventually what we're all aiming for. So that's why in this case we actually proceeded with stenting of the proximal part after ballooning and rotablation. So that's why in this case we actually proceeded with 2 drug-eluting stents, the 3540 proximally and the 3026. Remember, on the IVUS the MLA of 2.1, but in a vessel with a previously expanded stent with a diameter of 2.8. So with that we decided to safely proceed with a 3026. We post-dilated that with a trio non-compliant balloon and got a very decent angiographic result in which the MLA clearly increased. Another case is a patient with a bifurcation. We've already seen osteal left main disease, but also in patients in which it's not that clear where the lesion is. Intravascular imaging usually really helps you in order to appreciate the true issue of these bifurcation lesions, like in this case a lesion that actually was apparently limited to a proximal lesion, a circumflex, a little bit hazy maybe. But we decided, as we typically do, to first proceed with imaging. And what we actually found is, again, a case with heavy calcium, minimal lumen area here in the ostium part of the circumflex in the middle top panel with a area of 3.5. So what the IVUS actually shows you is first the severity, MLA 3.5 in a vessel with a reference area of 17.4, which is consistent with a vessel with a diameter of 4 millimeters, which makes the MLA of 3.5 clearly, at least from an anatomical perspective, significant. The second thing is that it shows you that the ostium of the LAD is nice and patent, as the angio suggested. But what it also shows you, and you see the bright white contours typical for the calcium, is that the rest of the image, specifically in the mid panel on the top, is completely black. This means there's no signal penetration, and this is a sign on intravascular ultrasound that is highly suggestive of very thick calcium. So a lesion that, for that reason, may warrant a bit more aggressive lesion preparation as compared to a standard semi or non-compliant balloon. So that's why in this case we decided to proceed with a scoring or a cutting balloon. In this case we used the Wolverine, but obviously a OPN or a lithotripsy balloon could have worked as well. But the point is not to be very dogmatic about the type of strategy you want to use in order to make a proper call on how to attack this lesion, but perhaps much more important is to assess whether the strategy you applied is effective. And in this case, you can again see pre-deballooning, the MLA was 3.5, but after the Wolverine, the MLA increased to 5.6. And importantly, you see actually now finally signal penetration at 3 o'clock and at 9 o'clock. I'll let the loop on the right side run again. So on the left side and the right side, you see on multiple locations, you see some points, you see signal penetration. And that illustrates that there are fractures in the calcium, which allows you to proceed with stenting. In this case, we used a 5016 Megatron stent, post-dilated the left main with a 6-0 balloon and got a beautiful result. So you would say angiographic, beautiful result, we call it a day and we go to the next patient. But no, that's obviously typically not what we do, because you have already the imaging catheter in place, so it's very easy to use it again to assess your post-PCI result. So I'll tell you the results in the circumflex was excellent, but what we also did is we rewired the LAD and actually looked at the ostium of the LAD after stenting this heavily calcified lesion in the circumflex. And this is the pullback from a LAD into the left main. So we start distally, you see no stent struts. And here on the top, now you go into the stent in the left main, but focus your attention at this point. At 12 o'clock, you see these bright white chunk of calcium actually floating in the ostium of the LAD. So that's obviously something that was clearly not apparent on the angio, but was apparent on the IVUS, and that made us led to do final kissing balloon dilatation. And after a kissing balloon, this is the final result. Again, the pullback from the LAD to the left main, in which you see that the chunk of calcium, including the stent struts that were not properly opposed, are now nicely opposed, and actually resulting in a really nice patent left main towards LAD trajectory, as you can also see on the longitudinal view on the bottom of the screen. So that was respect to bifurcations. What I think is another very interesting area to use intravascular imaging is patients presenting with ACS and STEMI in particular. And I will do that by illustrating just a simple case of a patient presenting with 69 years of age, presenting with a lateral STEMI, chest pain since about 1 hour, clear ST segment elevation. And then what we typically do is we bring these patients to the cath lab. We may do some thrombectomy, and may do a small balloon, and then do angiography and find something like this. In a patient with a right dominant system and a circumflex that actually doesn't look that big. But remember, we already did pre-ballooning, we gave some nitrates, we may have given a 2B3 inhibitor, and still this is the result. So what do? You keep ballooning, you do more aspiration thrombectomy, of which we know it perhaps doesn't work that well. So why not just do imaging? And this is a case that we actually enrolled in the Spectrum trial that we did with the support of Assist Medical in order to find the value of high-definition IVUS-guided PCI in patients presenting with STEMI. And if I show you this pullback, this is likely not what you anticipated. So if you look at image 4 on the right bottom of the screen, this circumflex is actually a 4-0 vessel in which no disease is present in the distal trajectory. In the mid part, distal edge, you see plaque, you see a plaque volume of about 50%. In the cross-section number 2, you see that this black cloud is floating in the lumen. Well, that is very typical of organized thrombus resulting from a plaque rupture that in this case happened a couple of hours prior. And you see a proximal landing zone in the circumflex with a vessel diameter of 4.5 millimeters, which is clearly higher than most of us would have anticipated based on the angiogram alone. So in this case, the reason we proceeded with the 428 DES, and then actually got a beautiful final angiographic result in a vessel that clearly appeared larger as compared to what was initially anticipated based on the angiogram alone. So with this, we used IVUS to really decrease our contrast load, decrease additional ballooning and thrombectomy, maybe even post-thrombectomy. But that said, we were able to conclude the vessel diameters, thrombus, no calcification. So that's why there was no need for further pre-dilatation. We implanted the stent and got a beautiful result without additional maneuvers. For those who want to read more on thrombus grading on IVUS, obviously this is not lesson number 1 where you do IVUS image interpretation, but we do believe it's extremely important to be able to start recognizing different types of thrombus. This is a very nice paper we did based on the Spectrum trial together with one of our fellows called Frederik Groenland, in a paper that was published in Eurointervention 2 years ago and provides a very nice overview of the different types of thrombus that you may find in cases with presenting with STEMI.
So very interesting cases, I would say, and I think it's really important to point out because this last patient really illustrated perfectly that I was kind of hard to streamline your procedure because you knew that you are intraluminal in the distal part where there was no contrast, and you saw the diameters of the vessel, and at the end it makes the whole procedure faster and more effective than just by eyeballing after an angiogram.